y'all probably can't see me, but can you hear me okay? Voice is good? You can hear? Okay. And I forgot my glasses at home today, so I can see the screen. I just can't see you all, but if you have any questions, I can probably see a hand raised. We'll try to make this kind of as interactive. If you want to stop and ask a question, certainly do that. I have nothing to disclose for this talk. We'll talk a little bit about some basic fracture management, and then some of the more like severe fractures and common fractures that we see, and then mostly spend some time on compartment syndrome at the end, because I think a lot of you may not be familiar with diagnosing it, and our nurses are often our first eyes at this. So we do really rely on your team effort in helping to pick up these kids who might be running into a problem with their injury. So childhood injury remains one of the leading causes of death. It accounts for a significant amount of hospitalizations per year, and about a quarter of children will have some injury a year, and a good percentage of them, about a quarter, will be fractures. And the United States has the highest risk. We are kind of in our busy fracture season now, and we'll be sort of slowing down for the next few months as the weather changes, at least in our area. But it's been pretty intense and high for a while, especially as kids transition back to school. Kids can hurt themselves anywhere. We do see a good percentage of fractures from school, and certainly we're in football season now. We're transitioning to basketball, so lots of recreational activities. And of course, we see a high number of higher energy incidents here, as well as fractures related to penetrating trauma. Just a little bit of background about kids' anatomy and why it's so unique, and why fracture management is different than adults. Kids have different areas, 4 main areas of the bone structure, and that is because the skeleton is still growing. So we have the area by the joint, we have the growth plate itself, we have the area right under the growth plate, and then the main sort of shaft of the long part of the bone. And you can have distinct injury patterns that can affect any of those areas, that then in turn affect sort of the severity, the complication rate, and what we do to manage it. In kids, the bone is much more resilient to stress. So we get sometimes these injuries that are more like plastic deformation, when the bone's been subject to some force and it bends the bone, but it hasn't actually broken the bone yet. We don't see that in adults. The periosteum of the bone is thicker as well. I liken this to the banana peel. So it's like the thick rind of soft tissue that helps support the bone, and it also recruits a lot of cells that we need for healing bones. So for that reason, a lot of these fractures that are severely angulated like this can be easily realigned and placed into a cast to heal. And the healing process really starts with the fracture itself, when a lot of cells come in to create this big inflammatory response. And the first thing that happens is that the bone starts to heal with what we call a soft callus, which is mostly cartilaginous and fibrous tissue. And then ultimately that goes through a process of ossification, where it heals with bone and forms a hard callus. And then over time, the cool thing about children's fractures is that they have a long remodeling process, where the bone starts to reorient itself to withstand the lines of stress that the bone is meant to hold. So that means the fractures don't have to be perfect to heal for children, because the body will change over time. So the remodeling phase is the longest phase, where we get this newly formed bone that comes in, it's maturing, and it's becoming more resistant to stress. So if there is any angular deformity that wasn't fully corrected when the child healed, the younger the patient is and the closer the fracture is to the growth plate in the bone, which we call the physis, and if the angulation is in the normal plane of motion of the bone, there's a good chance that the body is going to naturally correct that over time. So this is the example that I love to show parents. We can take a fracture like this, which is completely displaced. This is near the wrist. And if we just line it up in a cast, we don't have to have the bone perfectly overlapping. It may heal like this with the bone side to side, a little bit of angulation you can see there. And within 6 months, it almost looks like nothing ever happened. So kids are kind of like magic in that way. And for this reason, most of these injuries can be managed with a cast. but they're certainly not all treated the same. We just have some general rules that apply for managing fractures. So like I said, most are treated in a cast. Particularly closed fractures, that means fractures that don't penetrate the skin, or stable injury patterns, which many of them are. But even more severely displaced fractures can often be realigned and reduced with sedation in the emergency room or sometimes in the operating room and simply casted without need for surgery, like is much more typical for an adult fracture. So typically you want some sort of temporary splinting for the fractures, and then some of them will have definitive management in a cast after some type of manipulation, or what we call a fracture reduction, where we're realigning the bone and then supporting that in a good cast. So when in doubt, if this is a fracture that requires some sort of manipulation that's more urgent to care for in the emergency room, or something that can be splinted and sent out and followed up with us, just call ortho and we'll help you sort that out. So much like any other problem that you would encounter, whether it's on the floor or in the clinic setting or in the emergency department, there's always sort of some general principles that you should be thinking about of how you approach a patient. Obviously, the clinical examination, and I understand that some of you may not be totally comfortable with the orthopedic examination, but we'll teach you some, basic things so that it's not so scary, and you have more of an algorithm, just like you would listen to the heart or listen to the lungs. So usually we have some sort of initial immobilization to give that fracture some stability, to give the soft tissue some rest, and to provide some comfort for the child, even if they're waiting for sedation or a resident to come down and manipulate the fracture. Some type of temporary immobilization is helpful, or even if it's for transport from one unit to another. Proper imaging, we'll talk a little bit about that. Elevation is key. A lot of these fractures can get swollen and can get swollen very quickly, which can lead to some other problems. So keeping the limb, whether it's the arm or the leg, elevated properly. Pain management, obviously these kids need pain management just to get a proper x-ray sometimes, even to do some sort of splinting, even before considering doing a reduction technique. And then rule number 1, do no harm. So you want to prevent evolving complications as best as possible. So on the exam, much like you would examine any other body system, you want to start with some sort of gross inspection of the limb. So there's some obvious things that you can see. There's a deformity, there's not a deformity. There's swelling, there's an open wound with a deformity. You automatically want to think that fracture might be open, which means the bone may have penetrated the skin, even if you're not staring or looking at the bone. A wound like that over a deformed, swollen arm tells you that that's probably an open fracture. Tenderness, so then you can kind of examine where the child is tender. Is it near the joint, or and localize that. Understanding some sort of basic motor and sensory examination, being able to look at the finger movement, being able to look at the foot or the toe movement, and then some sort of basic sensory examination, and we'll review that when we talk about compartment syndrome. And then the last thing would be the vascular status, so palpate the pulses. If you can't palpate them, is the hand or the foot warm? And then sometimes getting the Doppler so we can sort of examine, because sometimes these vessels are in spasm, and so sometimes you can't feel pulses on these fractures until we get them properly aligned. And obviously, if there's an ischemic limb, that's much more of an emergent situation than a child who has a well-perfused extremity. And then document that exam. You want to know where you start, because these kids may sit in the emergency room for 12 hours getting more and more swollen, and then all of a sudden that nerve that was working is no longer working. That pulse you could palpate is no longer palpable. These things happen, so we need to know where we start, even if it's some sort of basic examination, and then knowing sort of how things are evolving potentially over time. So the goals of immobilization are obviously to provide comfort for the child. Definitive immobilization, the goal is to prevent loss of alignment, so we want to make sure that it maintains proper alignment of the bone while it heals, but it also calms the inflammation of the soft tissue. So even if we know it's an operative fracture, but they're waiting for surgery that's going to happen the next morning, that temporary splint can still do all of those things. So that could be a cast, a splint, or some sort of type of brace, depending on what the fracture pattern is and what it really needs. But you have to be aware, anything that we can do can cause a complication to the child, right? So an improperly applied splint or a cast can lead to big problems. So if it's wrapped too tight, sometimes we get a lot of swelling. We see lots of skin rashes. If there's not a proper barrier between the skin and the cast. Kids love to stick things down their splints in their cast, so we always have to educate so that the foreign body, it looks like that somebody probably shoved down their cast, that they can cause a pressure wound when we go to take the cast off. And lack of proper padding, particularly on the heel, is a very vulnerable area, and we see this time and time again for these splints that are often applied in the emergency department because the kids are super active and they move. And that splint can kind of like slide, and it creates a lot of shear force, and the heel is a very vulnerable area to get a pressure sore. So we always caution parents to sort of look out for those things. Any pain in the splint or the cast, probably take that seriously. Even a simple ACE bandage can cause big problems, and we see this all the time as well. Even if you think you're not applying the ACE bandage too tightly, there's going to be more swelling that develops over the next 48 to 72 hours. So we've seen things from as simple as skin abrasions from the ACE bandages, worsening swelling, and we've seen ischemia, even loss of digits from either a tightly applied Coband or an ACE wrap. So always be mindful of how you're applying something. Beware that there could be some more swelling with that. Educate and counsel families that, hey, you know, if things look like they're getting like more swollen anywhere distal to where this bandage is applied, or if the child's having excruciating pain, like we gotta, you know, take that bandage down and make sure that it's not too tight, causing an issue. See, there's some swelling that you can see in the hand of that girl that had a splint on for an elbow fracture, and there's little red marks or little abrasions from the ACE bandage sort of tight across the antecubital fossa. So all of these things can cause issues. A cast can even cause a compartment syndrome, so that's been known to happen as well. We talked about pressure wounds in the heel particularly as the vulnerable spot. And then thermal injury, that's really more for us when we're removing a cast, so there really should only be a trained person using a cast saw to remove a cast because it doesn't cut the skin, but it can burn the skin if it heats up too much, and certain patients are a little bit more vulnerable than others. And last but not least, we always say there are no hypochondriacs in a cast. If a child is incessantly complaining about their splint or their cast, something is probably wrong underneath it, and that's our cue to be able to check it. Then we have the patient that is more difficult to know if there's a problem or not. So that means that we have to be more vigilant as providers about making sure we avoid these complications. So that's the child who can't communicate from either developmental delays or somebody who's intubated and sedated in the unit, somebody who has impaired sensation, from a variety of neurologic conditions, or spasticity where they're very tight and you try to immobilize them and their muscles are very spastic against the cast and they could be more likely to get some pressure sores. So the proper way to elevate, for example, a long leg or a lower extremity cast would be to float the heel. And sometimes orthopedics will place a nursing order to say, elevate but float the heel. So that means the heel should be suspended, just like that picture with the towels or the blankets underneath the calf, but the heel is actually not touching anything. And that's the best way to offload that heel in a cast, particularly in a patient who can't tell you if there's a problem. Does that all make sense? So float the heel. And then the thermal injury, and that can happen in a couple of different ways. The cast is, it's set by an exothermic reaction, so it actually gets pretty warm when we place the cast, the same for the splints. So we've got a couple of rules on our end to sort of avoid those problems. And then also, again, just a reminder that cast saw burns are real. They can cause a lot of scarring. They can actually be deep. And so the only person who should be using a cast saw to remove a cast is somebody who is trained to use that cast saw. So even if you think that you're being helpful in the emergency room, that a cast needs to come off and you feel like it's easy enough thing to do, just contact orthopedics, and all of our residents and staff obviously are trained to be able to remove the cast safely. So the next thing we'll talk about is just the imaging. So I think the key thing is that the kids are painful and they've got these like displaced fractures and we're trying to get x-rays and everybody wants to spare them of the pain, so sometimes we don't get them the proper x-rays. They need the pain medicine before they go get their x-rays because we need proper x-rays to see what's going on. So we need what we call orthogonal imaging, which means we need at least two views that are opposite of each other of the area in question. So for example, this is a kid that was seen at an outside community emergency department. He gets this x-ray for an elbow injury, and the radiologist reads it as a minimally displaced distal humerus fracture. And any one of us would look at that and say, that has to be a completely displaced fracture. Where's the other view? And on the other view, you see this. This kid was splinted and sent out with a quasi-like urgent fracture that needs surgery because the child's at risk of neuromuscular injury as well as compartment syndrome. And probably what happened is the child was in pain. They got this x-ray. The radiologist interprets it as this minimally displaced thing. And of course, they didn't get an appointment until a week later in the orthopedic office, and that becomes a much more complicated problem to treat, but also risk that that kid could have gone home and had a big vascular issue or a compartment syndrome that had a irreversible damage to the muscle. So we need to get the proper imaging, but that generally is not a problem at our institution. But just remember, we want to make the child as comfortable as possible in x-ray. We talked about the elevation, and I think that really should start when the kid hits the door. Because some of these kids are waiting in the emergency room all night to get their sedation so that they can get their manipulation, and all the while they're getting more and more swollen. So propping the extremity up on pillows, blankets, we don't have these sort of prefabricated like foam pads or ramps for the upper or lower extremity injuries, but we do have plenty of blankets and pillows in the hospital, so there really should be no excuse that we don't start elevating immediately to try to prevent some of the evolution of this swelling as best as we can. So who then gets surgery? Pretty standard that most open fractures, so anytime the bone pokes through the skin and communicates with the environment, there's a higher risk of infection. Many of those will get treated with some type of debridement of the fracture site to reduce the infection risk, and then often some type of fixation internally because the fractures tend to be more unstable. So if there's a completely displaced fracture or a fracture that's very unstable and we just can't maintain acceptable alignment in the cast, those fractures may get surgery. And then in the child who has multiple injuries, so a multi-trauma patient that may be in the ICU, sometimes just for ease of mobilization or getting the patient up and going, we tend to fix those fractures a little bit more surgically. We might be worried about putting a cast on a patient who's going to be intubated and sedated for a while and not tell us if there's a problem with the cast or swelling. So those are all reasons why we might be considering surgery for certain fractures. So we'll move into any questions before we move into open fractures. Is that all good? Okay. So open fractures, this is an obvious one, but there is a range of severity, obviously, based on the classification system, which is typically the size of the wound and then a little bit of the degree of contamination of the wound, and then whether or not there's a vascular injury associated with it. So obviously our most minor ones, which are pretty common here, like in upper extremity injuries or forearm injuries, where it's pretty clean. There can be a pretty small wound, but it's obvious that the wound is directly over the fracture site, but typically the bone pokes through the skin and then goes back under the skin, dragging sort of all that bacteria with it. So you may not actually be seeing the bone in that situation. And then type 2s and 3s, we start to get bigger wound size. And then the type 3s are sort of compartmentalized into how much soft tissue is lost over the bone. Usually they're typically higher energy trauma. And then the worst type also has like a vascular injury associated with that. And so obviously the higher you go in the grading scale for an open fracture, the more likely there's some sort of complication. The bone may not be at risk of healing, or there could be a risk of infection, or even in the most severe types, an amputation. So the higher the grade, the more likely there will be some sort of sequelae or complication related to that injury, all the things that we discussed. But I would say even for a child, a grade 3, like the worst, the highest open fracture, can get very good functional results. This is a real patient that came here after being pushed off a boat accidentally and getting his leg caught in a propeller. And this is sort of what kind of a mangled foot, like a bad open fracture, looks like. But we'll sort of, I think I got some follow-up photos to that patient who was actually treated here. But if we follow our principles, and that starts with like early detection and treatment in the emergency department, we can handle sort of even the severest of trauma, and the kids can turn out with a pretty good functional result. So number one, antibiotics, antibiotics, antibiotics. So if you see an open wound over a deformed extremity, the goal is to get that antibiotic in the patient as quickly as possible, and typically that's ANCC for most of our fractures, and then if there's some contamination, and we add in some other antibiotics per protocol to cover some different organisms. But the most effective thing at decreasing the risk of infection for an open fracture is the timely administration of the antibiotic. And at our institution, our benchmark is 1 hour. So they hit the door, we got to get that antibiotic within 1 hour. So even triaging these patients, they don't hesitate to give that here. The timing of debridement, so us taking them to surgery to start cleaning out the wound and doing whatever fixation we need to align the fracture, that's actually less important. And so unless it's like severely contaminated, like that last picture that we saw, that might be more of an urgent situation for debridement in the operating room. But most of these kids will be kind of temporarily cleansed at the bedside, splinted, they get their antibiotics, and probably will be prepped for surgery the next day. So the antibiotics is the single most important thing in our literature. So early treatment, so some sort of fracture stabilization. Again, the goals of that immobilization are to protect the soft tissues, to promote union of the bone, and that can be either some sort of internal inside the bone fixation or external fixation like you see in this picture. So these bad open injuries really allow us to be pretty creative of what does this child need to accomplish all of these things, to keep the bone in reasonable alignment, to allow access to wound care if there's going to be a big open wound that might need later surgery, and what's going to allow this child to heal optimally. So again, if you look at this x-ray, it doesn't take a radiologist. You can all probably tell that something doesn't look right here. That bone is completely displaced and it's sticking out beyond the confines of the skin on the x-ray. So that's a bad open fracture that was treated with an external fixator. And thank goodness, because the patient had all of this like full thickness sort of skin loss that developed after the swelling related to the trauma. And so external fixators are great for this because they don't have a cast. And so if there's going to be our wound care team or our nursing staff doing a couple of times a day dressing changes so that we can kind of treat this ischemic area, then the external fixator really allows access for you to be able to get in there and do what you need to do. So this is what I'm talking about, our sort of creative thinking. We use a lot of wound vacs here. If you all had experience with the wound vac assisted device, so the sponges that are connected to this negative pressure system and to basically provide a sterile dressing to a large open wound that may need multiple return trips to the operating room or need some sort of delayed closure technique either with us or with our plastic surgery team for coverage. It also decreases deep infection rate. It helps bring in good vascular supply to the wound bed. So getting kind of familiar with how the wound vac machine works and is important because you'll see a lot of these as well, no matter what unit you are in. So back to this patient who has sort of this like mangled extremity is kind of how I would describe it. There's bone loss. It looks to be some sort of soft tissue loss. There's multiple tendon injuries. There's a vascular injury. This is sort of how we would approach that. So obviously getting antibiotics right away. This is somebody who's going to have a more urgent time to surgical debridement. So that patient went directly to the operating room. Initially, we were just sort of cleaning things out and sort of letting things evolve. So the child went back to surgery like a few times, just sort of cleaning out the dead bone, any contaminated tissue until we felt like things were relatively clean. And we kind of managed the child just by keeping the foot aligned and in a temporary splint, probably for a few days to maybe a week before we put on this definitive external fixator. We basically kind of made the foot look like a foot again. So there was a lot of bone missing, but we sort of lined things up the best we could, put some sort of like smooth wires for limited internal fixation, knowing this kid was going to be at very high risk of infection after having this injury in dirty river water. and then place the external fixator on. And for this kid, that was his like definitive fixation, and that was on until everything sort of healed up. And sometimes we have multiple services involved, so plastic surgery really helps us out a lot with these complex wounds. And so over time, his wounds healed. Most of that was able to be closed, actually, so he didn't have as much soft tissue loss as everybody anticipated from the beginning. And this patient is being prepped from the beginning that this may result in an amputation. We don't know how this is going to go, if it's going to heal, if it's going to get a bad infection. But, you know, following our basic principles, we were able to get things relatively aligned. He did sort of heal. He needed a small skin graft, but a pretty small area of a skin graft compared to what you would have expected from the beginning. The foot was vascularized by his remaining blood vessel, even though he did have a traumatic injury to the tibialis anterior artery. And this is probably maybe 6 months after his injury and playing basketball. So this goes to show you that kids are super resilient. I think if we can be very patient with our process and we work together as a team to follow all these steps to the best we can get a good result with a very severe injury. Wearing a brace there, but I just saw him recently and he's no longer even wearing a brace and functioning quite well. So he's got a foot that was saved, and the family's super grateful. And that, you know, from everybody who saw this child and was involved with this family from the very beginning. Any questions regarding open fractures? Okay. I think we're doing okay on time. So I'll touch base next on supracondylar humerus fractures, because this is probably the most common elbow fracture that we see in our hospital. Typically accounts for about 55 to 80% of all pediatric elbow injuries. Again, they come in a variety of flavors, so a variety of severity. Some are very mild. Most of them need surgery, especially the completely displaced ones, which are the type 3s, which are what you see in this picture. The key thing to know about these is they can be something that needs more emergent attention. There can be vascular compromise in a good 20%. And I would say about 10% at least have a nerve injury when they present. And the reason for that is if the fracture displaces, it tents right over the brachial artery and the median nerve. So it's actually very common for these kids to present with an elbow looking like that, very significant ecchymosis. Sometimes the skin could be puckered or tented by the fracture if it's very displaced. And so getting a good neurovascular examination from the very beginning will help us decide how urgent it is to be fixed. So, and again, our goal in surgery is to restore normal alignment of the distal humerus. We typically will place pins to hold the bone in position while it heals because they're very unstable. This is all done in the operating room. And then obviously we want to make sure that the vascularity to the hand is maintained, and we want to avoid any long-term sequelae or complications of tissue ischemia. So we want to monitor for two things, whether they have ischemia because they have some sort of vascular injury that needs repaired or attention, or they can get ischemia because of a compartment syndrome that develops with swelling that then impairs the blood flow adequately getting to the muscle. So two main things that can happen that we want to avoid for these patients, because if those things happen, then we look like we're dealing with contractures of the muscles, a hand that's not functioning well, much like that picture there, and that requires a lot of intervention in the future. So these injuries can be bad. So I just want to bring your attention to what we call the pink pulseless hand. So a number of these badly displaced ones will come in, and you may not be able to feel or sometimes even Doppler a pulse. But if the hand is nice and pink and perfused with brisk capillary refill, then that means that the forearm musculature is getting adequate collateral blood flow from the rich network of blood vessels around the elbow. So as long as the hand is getting perfused, then we're not in such like an emergent situation. So this is actually not an uncommon scenario where we've got a pink perfused hand, but the extremity is pulseless. And so obviously orthopedics is going to be involved in these, and we'll, let you know what needs to be urgently treated or not. But documenting again where that pulse exam is on arrival, and then sort of watching what happens to that overnight as the vessel spasms and the arm starts to become more and more swollen. So the first thing that we do, even if there's no pulse, is to fix the fracture. Less commonly, there's no pulse and the hand is white and ischemic. If that happens, obviously, we're still looking at going to the emergency room just on a more emergent basis to reduce and fix the fracture. And about 50% of the time, that pulse will come back once we fix the fracture. So oftentimes the vessel is spasmed, it's draped over the fracture site. Rarely is it completely damaged or completely lacerated. I've seen that only once. And the good news is that there's so much good, rich collateral blood flow around the elbow that even if there was a complete brachial artery laceration, oftentimes there's still enough to restore flow and to maintain a pulse distally so that the musculature is getting well perfused. If, we fix the fracture and the hand is still ischemic and there's no pulses, that's when we consult our vascular team, which we do not actually have in the hospital. We have an interventional team, but we do have a protocol here for transferring patients. Typically to Hopkins is our first choice for young patients. For older patients, they can go to hospital center where they have a vascular surgeon who can deal with these more severe injuries that are actually very rare. So in general, like our intermediate follow-up shows that these patients do pretty well, have really good, excellent outcomes. They all ultimately get palpable pulses eventually, even the ones that had like ultrasound findings that there was a true brachial artery injury of some sort. So as long as they've got perfusion, that's really the thing that we are looking at. And at our institution, over like a 10-year period we had looked, we didn't have any vascular repairs. And I would say that our percentage of patients who came that had that pink but pulseless hand was pretty on par for what we expect in the literature. And the compartment syndrome rate is also pretty low. So we did have some compartment syndromes, but no patient that needed an actual vascular repair. And again, that's because once we fix the fracture, oftentimes that collateral flow is enough or the spasm in the artery resolves, and that's able to support the hand. Questions about elbow fractures. We will see a lot of those for sure. Compartment syndrome is sort of, I think, the last or biggest thing sort of I wanted to review with you all. Has anybody seen a patient with a compartment syndrome? Know what that is? Do we know what compartment syndrome is? Okay. So we'll review all of that and we'll review some sort of exam findings because our nurses, like I say, you really are our eyes and our ears, and you're going to be with that patient a lot more than our resident can be there monitoring a patient who might be at risk. And so knowing some basic things, warning signs to look out for so you know when to notify us right away is critical, because every year we have a nurse pick up a patient who has an impending compartment syndrome that needs urgent surgical treatment. So it's a little different than maybe what you've learned even for adult patients, because the kids can be very difficult to examine, especially the little ones. So the 5 Ps, like the pain with passive stretch, the pulselessness, these are less reliable in children, but the single most important factor that indicates an evolving compartment syndrome is an increased need for pain medication. That's the most sensitive indicator of a developing compartment syndrome in a child. They're kind of doing okay, and all of a sudden they're like needing more and more and more, and the medication isn't touching them anymore. You're constantly calling the resident to add in orders for more medication. That's not normal. Or if the child starts to become very anxious, like some children are anxious at baseline, so it's difficult, but you've got that like increasing need for pain medicine, very, very anxious child. That should be our first cue that something's not right here. So you can obviously have swelling or significant pain that's not resolving with elevation in the pain medications. And the other thing that's really key too would be a change in a neurovascular examination. And so every now and then we get a child who's maybe not demonstrating as much pain as we think, because there could be a language barrier, or they could be too afraid to speak up about how miserable they are. Sometimes you just look in a kid's eyes, and even though they may say their pain scale is a 3, you could just tell they're suffering. So sometimes it just takes a good clinical judgment to say this child is suffering. Or a change in the neurovascular exam. They were feeling the back of their hands, before, and now they're having some numbness or some paresthesias, or they were moving their fingers really well before, and now they're not moving their fingers so well. That's also a sign that there could be an impending or an active compartment syndrome. This, I think, was our, I'm going to skip over this slide. This is just our experience with compartment syndrome for supracondylar humerus fractures. The bottom line is it's pretty low, even though those elbows can look really nasty and they can look very swollen. Still probably less than 1% actually were treated for a compartment syndrome. So a lot of them will do well, like I said, as long as that hand remains pink and perfused. So just compartment syndrome in general, so supracondylar humerus fractures aside, really any fracture, particularly we worry about the lower leg, so the tibia. High energy, so the higher the energy, the more likely that there's some soft tissue injury, there's more likely that there could be bleeding into the muscle compartments. But it doesn't have to be a high energy injury. It could look like a relatively simple fracture pattern like this, but if it was a crush injury that caused that simple fracture pattern that looks relatively benign and non-displaced, they're still at high risk for a compartment syndrome. If you have a kid with like a hemophiliac or a bleeding disorder where they're more susceptible to be bleeding into the muscle compartment, that's another risk factor. Certainly we can see it with other random things like IV infiltration or neonatal compartment syndrome, but the purpose of this is really to detect it in patients who have had traumatic injuries. So what it means is that there's increased pressure that builds up within the muscle, and the pressure becomes so high that it affects the gradient, so that the blood flow getting into the muscle is decreased because it's not allowing sort of that exchange of the nourishment, the oxygen delivery through the tiny vessels into the muscle because the pressure is sort of backing up. So it is a surgical emergency. And if it goes undetected, it can actually cause permanent tissue ischemia or muscle ischemia, muscle damage, which can then lead to permanent numbness, weakness, or loss of function if it's not treated and caught right away. So it is important to detect it as quickly as you can so that we can treat it. So what is a compartment? So in the leg and in the arms, there's different muscle groupings that are all lined by what we call fascia. Within that muscle grouping, there's typically a nerve and there's a blood vessel that typically runs with it. I kind of say the fascia is like the casing on a hot dog. It's kind of tight, right? It doesn't have much elasticity to it. So that muscle swells, and all of a sudden it becomes very constricted by that casing because it's got no more room to swell. So in the lower leg, there are 4 main compartments, and we'll review sort of what each one of those does. There's an anterior, a lateral, and then there's 2 compartments in the back or the posterior aspects of the leg. The anterior compartment, the way to test that, and any one of these or a combination of them can develop a compartment syndrome. So you kind of need to have a little sense of what you're testing for. Although not that I expect you to remember what nerve is in what compartment, but just have a basic idea of your exam to know, hey, something's not right. This kid's not able to move the toes in this direction because that weakness could be an indicator of the compartment syndrome. So the anterior compartment runs down the front of the lower leg, and it's responsible for what we call dorsiflexion, or lifting the foot up to the sky, and toe extension, which is pulling the toes towards the nose. And it's innervated by the deep perineal nerve, and so the way to test the sensation is in the first web space. So between the first and the second toe, that tiny patch of blue there, that's where you would test for the anterior compartment. And so this is how you ask the child. This is my daughter, who was only, I think, 4 at the time, and she's cooperating pretty well. So even a little kid, when you ask them to do things, they should be able to cooperate pretty well. So say, move your toes towards your nose or move your foot towards your nose, and you should see if the patient is immobilized in a cast, you can at least evaluate the toe movement. If they're not in a cast, you should be able to see the whole ankle move just like that. So once again, the toe extension, you really want to kind of isolate the toes. So if they're not in a cast, sometimes you can hold the foot just so that you can make sure they're not cheating. So sometimes if they have toe flexion, they can bend their toes down and then the toes rebound back up, and people think that that's actually extending their toes. But what you really want to do is have them start from a resting position and then lift their toes up. The second one is the lateral compartment. So that's on the side, the outside of the leg by the lateral malleolus. The sensation for that distribution is the whole top of the foot. So everything else on the top of the foot, aside from that like first web space where the anterior compartment sensation is. And then this movement is what we call eversion. So you can really only test this if a child is not immobilized in a cast or a splint. And what you're looking for is the small toe to be moving out towards the side, kind of like a windshield wiper. But for that one, probably the sensation is going to be a little bit more important for you because a lot of these kids are going to have some type of immobilization. And then lastly, the posterior compartment is really divided into a deep and a superficial. But together, these two compartments give you what we call plantar flexion, which is pointing the toe down or pushing the foot on the gas pedal and flexing the toes down. And the sensation distribution here would be on the plantar aspect of the foot. So the whole plantar aspect of the foot is innervated by the tibia nerve, and if that starts to change or you have weakness in that department, then we will worry about the posterior compartment developing a compartment syndrome. So plantar flexion, here we go, is foot on the gas pedal. Some little kids may not know what you're talking about, so you can say point your toes down or push against my hand. And same thing, if they're in a cast, you're just going to observe the toe flexion. Does that all make sense to everybody? Okay. And then the next common location for a compartment syndrome would be in the forearm. So we talked about the supracondylar humerus fractures, but even forearm fractures can get very swollen and lead to a compartment syndrome. So the three main nerves that we would be looking at for the upper extremity, and a few things that you want to just sort of know basic ideas to test. So the volar compartment is obviously on the volar or the anterior aspect of the forearm. It's responsible for wrist flexion and finger and thumb flexion, so making a fist. There's two nerves that run in that compartment, the median nerve and the ulnar nerve. Again, you don't have to know all of this, but if you're testing sensation, you want to kind of know in the hand where we're testing sensation, not just like feeling the fingertips. Yeah, they can feel the fingertips. I always say do the index finger and the small finger, and then you've tested the two nerves in the volar compartment. So index finger, the palmar aspect, and the small finger, palmar aspect, and that gets you that nerve distribution. And then you would ask them to make a fist, or flex their fingers, flex the thumb, sometimes make the A-OK sign. That generally says that those nerves are working pretty well for the median nerve. And then the ulnar nerve does what we call finger abduction. So that's making the number 2 sign, or you can say scissors. It looks kind of like this, like spreading the fingers apart, crossing them over. And that usually gives us a good sense that the ulnar nerve is working fine. And the last one is the dorsal compartment of the forearm, so that's on the back of the forearm. It's responsible for the opposite, so wrist extension and thumbs up and finger extension. And the sensation for the back compartment is going to be on the back of the hand. So usually I say back of the thumb is the best way to test the radial nerve. So our 3 sensory groups again are going to be back of the thumb, index finger, small finger, and then you've tested all the nerves in the forearm, even if you don't remember what they are. If any of those are having weird sensory findings, then again, that could be an indicating that it's getting squeezed by the swelling. And this is what extension looks like. This one you can kind of get fooled a little bit. You almost need to have the child start from sort of a flat position because they can sometimes cheat and do this, and that's actually not extending their fingers. So if they start from a flat position, you can do a thumbs up, and then have them, I know my daughter's super fast, thumbs up, and then have them raise their fingers up, which is your finger extension. One more time. So that's getting your dorsal compartment, which is the radial nerve. And again, these are sort of the groupings of the compartments by color of what they look like in the forearm. So I'm mainly sort of spending a lot of time on this because what you can do is just recognize it. Again, you don't have to memorize all these things, but have this like basic sort of algorithm in your head of how you want to test and recognize when something's changing, recognize when a child is becoming anxious or needing more pain medication, and let us know. And we are here to help, and our residents are very good, and they generally are checking on these patients who are at high risk, like every few hours or so, but sometimes they get caught up in the emergency room, they're busy, and you guys are there. So don't hesitate to call if you think something is not quite right. The first thing we may do, or you can even do while you're waiting for an orthopedic resident to come, is to loosen all dressings or splints. If there's something circumferential on there, you can split the bandage. Make sure that the leg is elevated, and then maintain their blood pressures, because obviously this is a gradient. The higher the blood pressure, then the better the perfusion pressure is at baseline getting to that muscle. But if they're very hypotensive, then they don't have like a high pressure to begin with going into that muscle compartment that's developing increased pressure. So a higher blood pressure is better in this scenario. So again, in high energy injuries, these are going to be much more potential for greater soft tissue injury or for compartment syndrome. We talked about proper positioning of the patients, elevating the patients, doing serial repeat examinations, motor, sensory, and the vascular examinations, and frequent monitoring of the swelling. You may also, have a limb where you're like, hey, I saw it an hour ago and it wasn't this swollen, and it's clearly evolving, it's clearly changing. So good, consistent examinations and documentation is great. These are the 5 Ps that you may have sort of learned about in your adult training. Pain, remember that's going to be the most important one for us. Palpable firmness, true compartment syndrome, the leg or the arm will start to get very tense, very tight. Pain with passive motion, if you start to move the ankle and the child's like jumping off the bed like in screaming pain, that usually is also an indicator that the compartment can be affected. Paresthesias or numbness, weakness, and pulselessness is the very last thing. That means you've got real ischemia. That's a bad sign. So you never want to get to the point where it's pulseless. So you can have a raging compartment syndrome, but a normally palpable pulse. So don't be fooled by, oh, but they have good pulses, so I thought everything was okay. That's the last thing that happens, and that usually means we're like at a pretty advanced compartment syndrome at that point. So, and then we've got our 3 A's, which is what you're remembering for pediatric patients, right? So your increased analgesia requirement, I'm going to keep repeating this because repetition is good, increased anxiety, agitation. We can monitor the compartment, so it's really a clinical diagnosis. So if somebody from the orthopedics team comes by and is like, yep, we are worried, we're going to take that patient for fasciotomies. And patients who are like in the ICUs or who are not communicative or maybe a little bit more difficult to get an examination, we kind of rely on swelling or a high index of suspicion. And then the objective way is to actually measure the pressure in the compartment. And so by doing that, we are 2 ways to sort of clinically diagnose it. If any pressure is greater than 30 or 40 millimeters of mercury, then that's usually an indicator for us to do a fasciotomy. Or if the pressure is within 30 millimeters of mercury of whatever the diastolic blood pressure is, would be the other thing. So that's why the lower the diastolic blood pressure is hypotensive patients, the more likelihood that even a low compartment pressure might be within that 30 range. And if we sort of use those criteria, then usually we weren't seeing any residual sequelae. And what do? Is fasciotomies. So this would be an example of what a forearm fasciotomy would look like. These are big incisions. We have to release that fascia, that lining around the entire muscle compartment. And then oftentimes we'll have a wound vac or some sort of delayed closure, or sometimes even a skin grafting if we can't get the wound closed in time. In the lower leg, we talked about different compartments. Again, you don't need to memorize exactly what those are. But this is what fasciotomy wounds look like in the lower leg. This is a patient who had sort of a delayed detection. Again, this is by a nurse. It was a little bit delayed, but it was still picked up. You can see that there is like a strip of some ischemic muscle that's not bleeding right in the center of the compartment there. But once we debride and clean that all up and get closure that could require a skin grafting, even with that amount of muscle loss that we saw, even though it was picked up maybe a little bit later than we would have wanted it to be, it got pretty good function. You can see him dorsiflexing. That's me resisting him, and he's walking pretty well without a limp. So these kids recover, so never think that it's too late. Obviously, just notify us if there's any concerns at all, and always assume full recovery in kids. And that is wrapped up. Good. Any questions? Easy crowd. All right, everybody feels good about compartment syndrome? Everyone's going to call ortho? Good. All right, I think